So now we are going to start the next topic, that is the anterior triangle. We have already covered the posterior triangle. So in this diagram, firstly, I want you to understand the boundaries. So here in the anterior triangle, you can clearly see the boundaries of anterior triangle is formed by following structures. So in this, you can clearly appreciate that there is sternocleidomastoid muscle. The sternocleidomastoid muscle is forming the boundary for the anterior triangle, and you can also clearly appreciate that there is anterior neckline. So this is the midline of the neck. So anteriorly, if you tell about anterior triangle, it is bounded by anterior neckline. Posteriorly, if you talk, it is bounded by, if you want to understand by this image, you can see the sternocleidomastoid muscle is bounding its posterior border. Now, if you will see the apex part, apex is lying at the level of suprasternal notch, and its base is by the base of the mandible. Lower border of the mandible is forming the base, and the roof is formed by investing layer of deep cervical fascia. So I want everybody to first write down about the details of anterior triangle. So anterior triangle is boundaries. So the heading is boundaries. The boundaries of anterior triangle is posteriorly, it is bounded by anterior border of sternocleidomastoid muscle. Anterior triangle is bounded posteriorly by anterior border of sternocleidomastoid muscle. And if I talk about its anterior border, the anterior border is formed by anterior median neckline. Now, base is formed by the lower border of mandible border, that is stretching till the mastoid process here, and a line. So if I talk about the lower mandible border, I mean to tell that it is the line extending from the angle of mandible to that of the mastoid process. Apex is formed by suprasternal notch, and that of roof is formed by investing layer of deep cervical fascia. Investing layer of deep cervical fascia. Done. So this is about the boundaries of anterior triangle. Now I want everybody to know that this in the anterior triangle we have got 4 subtriangles. Okay, there are 4 subtriangles in the anterior triangle. So what happens in this image, what you see, the subtriangles have also been shown here. So you can see there is a submental triangle. The green color is the submandibular triangle. The blue color is the carotid triangle. And you can see there is also a muscular triangle shown here. So these are 4 sub-triangles which is shown here, and these are the 4 sub-triangle in the triangle in the anterior triangle, and we have to know the boundaries of individual triangle, and we have to know the contents and the flow structure of this individual triangle. So I would like to firstly talk about the submental triangle. Actually, here what happens, there is there is omohyoid muscle and there is digastric muscle. So omohyoid and digastric muscle divide the anterior triangle into 4 subtriangular spaces. So let's talk about firstly the submental triangle. So when I am talking about the submental triangle is bounded on each side by, as you can see this diagram, this is exactly the submental triangle. So this is exactly the submental triangle. This triangular space, and this triangular space is bounded on each side by anterior belly of the green color muscle which you are seeing is the digastric muscle. So this is the digastric muscle, and anterior belly, if I talk about anterior belly, the anterior belly of the digastric muscle is forming the 2 boundaries of, on either side, the boundaries of submental triangle, and on base it is formed by the base of hyoid bone. The apex is formed by the symphysis menti. So please write down the boundaries of submental triangle. The boundaries is formed on each side. On each side it is bounded by anterior belly of digastric muscle, anterior belly of digastric muscle, anterior belly of digastric muscle. The base is formed by body of hyoid bone. The apex is formed by the symphysis menti, and the floor. If I talk about the floor is having two mylohyoid muscles, and these two mylohyoid muscles is meeting in the midline to form a mylohyoid raphe. The content of submental triangle is, it contains submental lymph nodes, it contains submental vein and commencement of anterior jugular vein. Now let's talk about the green color triangular area which is highlighted in this diagram, that is the digastric triangle. The other name of digastric triangle is, it is also called as the, it is also mentioned as the submandibular triangle. The reason is that why it is called that, because it is containing submandibular gland. So if I highlight this image, you can see this triangular area which is shown here is the digastric triangle. Now the digastric triangle boundaries. So if we talk about the boundaries, so if I talk about the boundaries, so see here, this is the muscle tendon which is forming the boundary. Okay, so now what happens if I am talking about the boundaries? Note down. The boundaries are following: digastric, antero-inferiorly it is bounded by. So this is antero. So please note down. Antero-inferiorly it is bounded by anterior belly of digastric. It is bounded by anterior belly of digastric muscle. It is bounded by anterior belly of digastric muscle, antero-inferiorly. And posteriorly it is bounded by posterior belly of digastric, muscle, along with it the stylohyoid muscle, So stylohyoid muscle, posterior belly of digastric, is forming its boundary postero-inferiorly. Antero-inferiorly we have got the anterior belly of digastric. The base is formed by, if I talk about the base is formed by, if I talk about the base, so the base is formed by base of mandible. And what about the apex? This is the apex, and the apex is formed by the intermediate tendon of digastric muscle, the intermediate tendon of digastric muscle. So very nicely you can appreciate the whole boundaries of the digastric muscle which I have shown in this image. So now let's talk about the floor of digastric muscle. So two important muscles has been shown in the floor, and here we can see mylohyoid and hyoglossus muscle. So there is mylohyoid muscle is there, and there is hyoglossus muscle. The floor is formed by hyoglossus and mylohyoid muscle, and also the muscle which is not shown is the middle constrictor muscle. So floor muscles are, so you can write down, floor of digastric triangle is having three muscles: mylohyoid muscle, the hyoglossus muscle, and the middle constrictor muscle. Now, if I talk about the floor, now I want to talk about the content. So the most important content of digastric is submandibular gland. So you can see there is submandibular gland located here. So there is submandibular gland which is the important content of digastric triangle, which is also called as the submandibular triangle. Other than that, so actually the whole content, if I talk about the content of anterior triangle, it can be divided as an anterior content and the posterior content. The structures residing in the anterior part of submandibular triangle or digastric triangle will be submandibular gland, submandibular lymph node, 12th cranial nerve, femoral, facial vein and the facial artery, along with the submental artery and mylohyoid vessels in the anterior part. If I talk about the content posteriorly in the digastric triangle, it is consist of the part of the carotid sheath content and also the structures traversing between external and internal carotid artery. That structures are deep part of parotid gland, styloglossus, stylopharyngeus, and that of the pharyngeal branch of vagus nerve and that of glossopharyngeal nerve. So actually, the cadaveric image I want you to show. So in this cadaveric image, you can appreciate the submandibular gland as the content. Also in this triangle, you can appreciate the facial artery. The facial artery has been shown. Along with it, you can see the facial vein is also shown. So these are the contents which is shown. And let's talk about the other contents. So the other contents which is there is the other contents which is residing here is the hypoglossal nerve in the anterior part. So we have got the hypoglossal nerve also residing. The structures between external and internal carotid artery in the posterior part, in the structures residing between internal and external carotid artery in the posterior part. So that is, and nerve to mylohyoid is also shown here. So this is the nerve to mylohyoid. So you can see here, this is nerve to mylohyoid has been shown. So nerve to mylohyoid, the hypoglossal nerve, mylohyoid vessels, and also the structures traversing between internal and external carotid artery. So I just want everybody to note down the content of digastric triangle. Okay, so we have done with the floor muscle, I think. Yeah, we have done with the floor muscle. And let's talk about the content. The content of digastric triangle. The content of digastric triangle is following. It contains in the anterior part. So firstly, I want everybody to note down the contents of digastric triangle in the anterior part. So in the anterior part, it is containing following structures. It is containing submandibular gland, submandibular lymph node, submental artery, mylohyoid nerves and vessels, mylohyoid nerves and that of vessels, mylohyoid nerves and the vessels. Also the facial vein and the facial artery. Now coming to the contents of digastric triangle in the posterior part, that is actually the structures traversing between external and internal carotid artery. So content of digastric triangle in posterior part. So when I am talking of the content in the posterior part of digastric triangle, a part of carotid sheath is also the content, and structures passing between external carotid artery and that of internal carotid artery. And the structures are, deep part of parotid gland, styloid process, styloglossus muscles, stylopharyngeus muscle. Then we have got 9th cranial nerve, and we have got pharyngeal branch of vagus nerve, 10th cranial nerve, that is the vagus nerve. And these are the structures traversing between internal and external carotid artery. Now the next triangular space is the carotid triangle, which is shown in this image. Carotid triangle is an important triangular region which is bounded by, so let me just enlarge this. If you will see this carotid, I would just like to show this carotid triangle in red color. This is a carotid triangle. So its boundary is, it is bounded posteriorly by sternocleidomastoid muscle. This is forming its posterior boundary. Antero-inferiorly, if I talk about antero-inferior aspect, it is bounded by the omohyoid muscle. This is the muscle. This is the superior belly of omohyoid, which is forming its antero-inferior. And if I talk about its superior aspect, superiorly it is bounded by two muscles, that is the stylohyoid and posterior belly of digastric. Okay, so this is the boundary. So please write down the boundaries of carotid triangle. Boundaries of carotid triangle. The boundaries of carotid triangle is following. Superiorly, it is bounded by posterior belly of digastric. Superiorly, it is bounded by posterior belly of digastric muscle, stylohyoid muscle, and antero-inferiorly. Antero-inferiorly, it is bounded by superior belly of omohyoid. Antero-inferiorly, it is bounded by superior belly of omohyoid muscle. Antero-inferiorly, it is bounded by superior belly of omohyoid muscle. Posteriorly, it is bounded by sternocleidomastoid muscle. If I talk about the roof of carotid triangle is formed by investing layer of deep cervical fascia. My dear aspirants, it is also important for you to note down that if I talk about carotid triangle, why it is named a carotid triangle? The reason is that it is having all the carotid arteries as is the content. It is containing common carotid artery, it is containing internal carotid artery, external carotid artery. So, all the carotid triangles are the content of carotid triangle. So, only it is termed as carotid triangle. Before that, I want everybody to note down the floor muscles. The floor muscles of carotid triangle it is having following muscles. Thyroid muscle is forming the floor along with hyoglossus, middle and inferior constrictor muscle. Middle constrictor muscle of pharynx and the inferior constrictor muscle of the pharynx. Done. Now coming to the contents of the carotid triangle. So, in this diagram you can see the blue color structure is internal jugular vein and the red color structures is having the internal carotid artery, the external carotid artery and that of the common carotid artery. Along with it, it is having the vagus nerve, carotid sheath and its content and many other structures are there. So, here you can see the important contents shown in the carotid triangle. So, if I talk about the carotid triangle, it is containing the last 3 nerves, that is the 10th, 11th and 12th nerve along with the common carotid artery, internal, external, internal jugular vein and vagus nerve are the important content along with the carotid sinus and carotid body. So, see here, this is a very clear cut diagram. So, in vagus nerve, hypoglossal nerve, accessory nerve. This is showing the carotid arteries and bifurcating into the external and internal carotid artery has been shown. So, it is bifurcating into external and internal carotid arteries. Actually, all these forms the content of carotid triangle. And also in the anterior wall of carotid sheath, we have got the ansa cervicalis. So, please write down the content of carotid triangle. The content of carotid triangle are following. It contains common carotid artery along with external carotid, internal carotid artery and its branches. Actually, the terminal branches of external carotid artery is not the content, but other than that, all other are the content of carotid triangle. Now, the other contents are, it contains carotid sinus, it contains carotid body as the content, internal jugular vein and that of 10th, 11th and that of 12th nerve. Other than that, the other contents is carotid body and the carotid sinus. Now, these are all contents of the carotid triangle. Now, after that, I just want to tell that we know that the carotid sheath which contain the internal jugular vein, vagus nerve and the carotid artery in its anterior wall is having ansa cervicalis. So, in its anterior wall we have got the ansa cervicalis. Ansa cervicalis is a nerve loop which is formed by the cervical nerve along with contribution from hypoglossal nerve. To understand the formation of ansa cervicalis, I just like everybody to show you this diagram. So, what you can see, it is having the lower limb and it is having the upper limb. So, the ansa cervicalis is having the lower limb and the upper limb. The upper limb is formed by C1 passing along with the contribution from the hypoglossal nerve. C2 and C3 is forming the lower limb, and all the infrahyoid muscle is getting innervation from this loop, that is ansa cervicalis, embedded in the anterior wall of the carotid chain. That is superior belly of omohyoid, sternohyoid, sternothyroid and inferior belly of omohyoid, except thyrohyoid. So, thyrohyoid is the odd man out, which is not getting innervation from ansa cervicalis loop. Actually, thyrohyoid is getting innervation from C1 fibers passing along with hypoglossal nerve. So, this is very important for you to know. Note down that all the infrahyoid muscles are innervated by ansa cervicalis nerve loop, except thyrohyoid. Except thyrohyoid. Why not thyrohyoid? Because thyrohyoid is getting innervation from cervical nerve 1 carrying the fibers of hypoglossal nerve. Now, I would also like to show you the ansa cervicalis in this cadaveric dissection. So, you can clearly enlarge this image, and when I enlarge this image, you can see the nerve loop. So, let me just enlarge. So, when I have enlarged it, I would like firstly to show you the superior and inferior root of the nerve. So, you can just so the nerve loop which I am showing you, this is the nerve loop which is I and SR is superior root and IR means inferior root, and this nerve loop which you are seeing is the ansa cervicalis. Now, the ansa cervicalis is situated on the anterior wall of the carotid sheath. So, the important structures we know in the carotid sheath is carotid artery, internal jugular vein and vagus nerve. So, I would also like to highlight that. So, here you can see this is the vagus nerve, V for the vagus nerve, the internal jugular vein and the carotid arteries. So, this is the carotid artery. So, see here exactly the nerve loop is running anterior to these structures, anterior to these three structures, that is IJV, vagus and carotid artery, and this nerve loop is ansa cervicalis embedded in the anterior wall of carotid sheath. Now, done with this. Now, the last muscular triangle, the last triangular space in the anterior triangle is that of the muscular triangle. Why it is called as muscular? Because it is not having any arteries, nerves and vessels, it is having muscles as the content. So, just enlarging this, and I want the black color outlined structure which you are seeing. So, you can see here this, I am just talking about this triangular space. So, this triangular space is the muscular triangle. So, this is the muscular triangle. This is the muscular triangle. So, let us talk firstly about the boundaries of it. So, if I am talking about the boundaries of this muscular triangle, it is bounded. So, it is bounded by anterior neck midline. So, this muscular triangle in the anterior aspect, you can see this midline of the neck is forming its anterior boundary, and if I talk about its anterosuperior aspect, so anterosuperiorly it is bounded by superior belly of omohyoid and posterior-inferiorly it is bounded by sternocleidomastoid muscle. This is the sternocleidomastoid muscle. So, this is the boundary. The muscles which is residing inside is sternothyroid, sternohyoid muscle. So, please write down the muscular triangle boundary. The first thing is that you should write down the boundaries. So, the boundaries of muscular triangle. The boundaries of muscular triangle is it is bounded anteriorly by anterior median neckline anterosuperiorly by superior belly of omohyoid and posterior-inferiorly by anterior border of sternocleidomastoid muscle. Done? Now coming to the floor structures and the content. Actually floor, if I talk about the floor muscle, 3 muscles are forming the floor and that is only the content also. So just see the content and the floor structures of the muscular triangle. I am just enlarging it. When I enlarge it, you can see here it contains the muscles. So you can see here it is containing the muscles sternohyoid muscle, thyroid, and it is containing 3 muscles: sternohyoid, sternothyroid, and thyrohyoid muscle. So please write down the content. So if I talk about the content and floor, both are similar. So I am writing together for the muscular triangle. The content and the floor structures are similar. It contains sternohyoid, sternothyroid, and that of thyrohyoid muscle, both as the content and the floor muscle. Now, I also want to talk about suboccipital triangle, which is an important triangular space, and we have to know the boundaries, content, and the floor structure. Suboccipital triangle is a small triangular space in the occipital region posteriorly. Let me just enlarge this image so that you can understand the boundaries. So, when I am talking about suboccipital triangle, its boundaries are following. It is bounded supromedially by rectus capitis posterior major muscle. It is bounded suprolaterally by obliquus capitis superior muscle. Supromedially, the boundary is by rectus capitis posterior major. Rectus capitis posterior major. Suprolaterally, it is bounded by obliquus capitis superior. Obliquus capitis inferior is forming the base or the inferior boundary of suboccipital triangle. So, just write down the boundaries. Boundaries of suboccipital triangle is, so very nicely you can see this image and you can understand. One more image I want you to show. So I will write the boundaries here so that it becomes very easy for you to understand, because so you can write on the heading boundaries of, you can write on the heading boundaries of suboccipital triangle. So this is suprolateral boundary, this is supromedial boundary, and this is inferior boundary. So here suprolaterally it is bounded by obliquus capitis superior muscle. I have written in short OCS. Obliquus capitis superior muscle is the suprolateral boundary. Supromedially it is bounded by rectus capitis posterior major muscle, and inferiorly it is bounded by obliquus capitis inferior muscle. So this is the boundary of suboccipital triangle, a triangular region situated in the posterior occipital posterior region. And the next important point is to know the content and the floor structure. So please write down the floor structures. Floor of suboccipital triangle. Floor of suboccipital triangle is formed by 2 important structures. One is posterior arch of atlas, posterior arch of atlas, posterior arch of atlas cervical vertebra, and the other is posterior atlanto-occipital membrane. Posterior atlanto-occipital membrane. Now, so we have done with this. Now let's talk about the content. So the content of suboccipital triangle is vertebral artery, to be more precise, the third part of vertebral artery and the suboccipital nerve along with it. So this triangular space which you are seeing, this triangular space is the suboccipital triangle, which contains third part of vertebral artery, the suboccipital nerve, and the suboccipital venous plexus. So write down the content of suboccipital triangle. Content of suboccipital triangle. The content of suboccipital triangle is following. So the content is suboccipital nerve, third part of vertebral artery, and that of suboccipital venous plexus. Suboccipital venous plexus. Now, so we have done with the suboccipital triangle. Next is to know some important arteries of the head and neck region. That is important that you should know the details of the important structures, that is the arteries. So if I talk about the one of the important arteries, external carotid artery. We know that the common carotid artery divides into external and internal carotid artery. So when I am talking about this bifurcation of the common carotid artery into external and internal carotid artery occurs at the level of superior border of thyroid cartilage. So that is, and then we can talk about the branches. So there are branches, there are 2 terminal branches and the 6 branches are given in the carotid triangle. So you can just write down the branches. Before that, external carotid, write down the details about external carotid artery. External carotid artery. So please write down. External carotid artery begins at the bifurcation of external carotid artery begins at the bifurcation of common carotid artery at the level of superior border of thyroid cartilage. At the level of the border of superior border of thyroid cartilage. Now the branches, let's talk about the branches of external. Actually there is a mnemonic for it, but firstly I would like to write the branches and then you can go for the mnemonic. Branches in carotid triangle. Branches in carotid triangle. The branches which is given in the carotid triangle is superior thyroid artery, lingual artery, facial artery, ascending pharyngeal artery, the posterior auricular and the occipital artery, the posterior auricular artery and that of occipital artery. So my dear aspirants, so here I just want everybody to note down superior thyroid, lingual and facial, all these 3 branches are anterior branches of the external carotid artery. Ascending pharyngeal is the only medial branch of external carotid artery and posterior and occipitals are the posterior branch of external carotid artery. The 2 terminal branch of external carotid arteries are the 2 terminal branches. So please write down the two terminal branches of external carotid artery is maxillary artery and the superficial temporal artery. Superficial temporal artery. Now, external carotid artery branches. So, there is a mnemonic for the branches of external carotid artery and the mnemonic is some anatomists like freaking out poor medical students. So, already I told you the branches. Can you see this image? So, the branches has been already told to you and you can clearly see the branches has been shown in this image. The 2 terminal branches are superficial, temporal and maxillary. Posterior occipital and posterior auricular and occipital are the posterior branches. Facial, lingual and superior thyroid are anterior branches and the only one medial branch is ascending pharyngeal. A very good mnemonic is there to memorize the branches of external carotid artery and that mnemonic is some anatomists like freaking out poor medical students. So here S for superior thyroid artery A for ascending pharyngeal artery, L for lingual artery, F for facial artery, O for occipital artery, P for posterior auricular, M for maxillary, and S for superficial temporal artery. Done. Now let's talk about the maxillary artery. So if I talk about the maxillary artery is one of the terminal branch for, if I talk about the maxillary artery, as I told you, it is the another terminal branch of external carotid artery. Now here this is a diagram in which you can clearly appreciate that maxillary artery is divided into 3 parts. And the division of 3 parts of maxillary artery is done by lateral pterygoid muscle. So only lateral pterygoid muscle is considered to be the key muscle of infratemporal region. It divides the whole maxillary artery into 3 parts. We have to individually know the branch from the first part, the branch from the second part, and the branch from the third part of maxillary artery. Okay. So here we can see the lateral pterygoid muscle. Okay. This is the lateral pterygoid muscle, this is the lateral pterygoid muscle, and the lateral pterygoid muscle divides the maxillary artery into 3 parts, first, second and third. Let's talk about the branches of individual part of the maxillary artery. So you can write down this information. Lateral pterygoid muscle, the key muscle of infratemporal region. Divides the maxillary artery into 3 parts. Divides the maxillary artery into 3 parts. First, second and third. And we have to know the branches from individual part. So for that, I just want everybody to note down. Firstly, understand this image and I will write it for you. Don't worry. So this is exactly showing you, so firstly making you understand the branches of maxillary artery. So first thing is that you can clearly see this is external carotid artery. You already know that external carotid artery, 2 terminal branches. One is the superficial temporal, and the other is the maxillary. So this is the maxillary. So this whole artery which you are seeing here is the third part. So this is the third, second and third part of maxillary artery. So this is the external carotid artery dividing into 2 parts. So here you can see this is the superficial temporal and this is the maxillary artery. Okay, this is the maxillary artery. So I will just write, this part is the maxillary artery. So I will just write MA as the maxillary. So this is the first part of the maxillary artery. This is the second part of the maxillary artery. Okay, this whole is the second, part. So just a minute, I will, okay. This whole is the second part of maxillary artery. Yeah, just a minute. Yeah. So don't get confused with this. Yeah. This is the second part. This is the third part. So that 3 colors so that you don't get confused. And this is the first part of maxillary artery. So 3 parts of maxillary artery. Clear? Now, branches from the first part. There are 5 branches from the first part. So there are 5 branches from the first part. And the branches are middle meningeal artery. The branches are middle meningeal artery, ascending accessory middle meningeal artery, anterior tympanic deep auricular, and the inferior alveolar artery. So how many branches? 5 branches from the first part. 5 branches from the first part, 4 branches from the second part, and 6 branches from the third part. So this is the second part and this is the third part. Now talking about the branches from the second part. The second part is giving pterygoid branches, temporal branches, masseteric and buccinator branches. The sixth part The 6 branches from the third part, that is sphenopalatine, the terminal branches, artery to pterygoid canal, pharyngeal artery, descending palatine, which will divide into greater and lesser palatine artery, posterior superior alveolar artery, and infraorbital artery. So these are all the branches. So let's write on the branches of maxillary artery. So all of you please write on branches. So firstly I would like to write the branches of first part of maxillary artery. First part. So first part, how many branches? 5. Anterior tympanic artery, deep auricular artery, middle meningeal artery, accessory middle meningeal artery, and inferior alveolar artery. Now coming to the branches of the second part. Second part branches, so write down the branches of second part of maxillary. Actually, all the branches from the second part of maxillary artery is muscular. So the branches are temporal branches, deep temporal, masseteric branches, pterygoid branches, buccal branches. Deep temporal means the branches to the temporalis muscle, masseteric branches to the masseter muscle, pterygoid branches to pterygoid muscle, and buccal branches to the buccinators. Now coming to the branches from the third part. Branches of maxillary artery from the third part, how many branches dear? 6. The 6 branches are infraorbital artery, pharyngeal artery, artery to pterygoid canal, descending palatine artery. This descending palatine artery again then divides into greater and lesser palatine artery. And lesser palatine artery. Other than that, it also gives posterior superior alveolar artery, posterior superior alveolar artery, and the terminal branch, that is sphenopalatine artery. The terminal branch, that is sphenopalatine artery. So all these are the branches of third part of maxillary artery. Now I would also like to tell you about the facial artery. Facial artery is one of the 8 branch of external carotid artery. It is the anterior branch of external carotid artery. It is having a tortuous route along the nasolabial fluid and along the medial angle of the eye. It is passing beneath the digastric stylohyoid muscle and will pass through the submandibular gland. So you can see the facial artery. This is the anterior branch from external carotid artery, having the tortuous route, giving superior inferior labile branches, and also gives branches in the cervical and facial region. So it is important to note down all the branches. It is important to note down all the branches of facial artery. So it gives 4 cervical branch, it gives 4 facial branches. The 4 cervical branches are ascending palatine, tonsillar, submental, and glandular branches. The 4 facial branches are inferior labile, superior labile, lateral nasal, and angular branch. Let's talk about the clinical correlation of middle meningeal artery. Now, middle meningeal artery injury is quite common at the level of pterion. What is pterion? Pterion is the level where the 4 bones meet. It is a H-shaped suture where 4 bones meet. I will show you that image. And that is the meeting point of sphenoid, temporal, parietal, and that of frontal bone. And exactly what happens if there is a direct blow on the level of pterion, there is injury of middle meningeal artery, frontal trunk, and it leads to bleeding, and that is called as a epidural hematoma. So you can see here, this is pterion, where frontal bones, where the frontal bone, parietal bone, P for parietal, then T for temporal, and S for sphenoid meet. And this H-sep suture which you are seeing, is the pterion, and there is the location of the vessel, that is middle meningeal artery, which is giving its frontal trunk, and this bleeding will lead to extradural hematoma or epidural hematoma. Now, I would also like to discuss few of the MCQs related to the topic. Question number 1. A 23-year-old Caucasian female is brought to emergency room unconscious after a motor vehicle accident. A linear skull fracture in this area of the junction of frontal, parietal, temporal and sphenoidal bone is seen on the X-ray. A branch of which of the following artery is most likely to severed in this patient? So, just now I told you pterion is the level. Pterion is the H-sep suture. Where is the location of middle meningeal artery, frontal trunk, and this is the source of bleeding, in which case epidural or extradural hematoma occurs. And my dear aspirants, we also know that middle meningeal artery is a branch of which artery? So, middle meningeal artery is a branch of maxillary artery. So, the correct answer will be B, maxillary artery. Now, I would also like to tell about a next important reason which is very important for you to know, because this has been asked so many times in your examination, that is the tongue muscle. So, tongue muscles is very important in tongue. So, tongue is a muscular organ which is having skeleton muscle, it is having fat, lymphoid and mixed tissue, it is having a tip, it is having a dorsum aspect, and we have to know the structures lying in the dorsum of the tongue, the muscles of the tongue, the action of the tongue and the nerve supply of the tongue. So, and also the arterial and the lymphatic drainage. So, when you see this is a specimen of the tongue, as you can see the schematic diagram. Here you can see the whole of the tongue is divided by sulcus terminalis, into anterior 2/3 part and the posterior 1/3 part. In the posterior 1/3 part, there is aggregation of the lymph node and it leads to the formation of lingual tonsil. In the anterior part, there is papillae, and we have got 4 types of papillae present in the tongue. The filiform is the most numerous one. Then we have got the fungiform papillae, we have got circumvallate papillae, and also the foliate papillae, which is exactly the rudiment one. It is exactly rudiment in case of human beings. So, we have got total of 4 papillae in the anterior part of the tongue. The division of anterior and posterior part of the tongue is done on the basis of sulcus terminalis. The posterior part of the tongue is having lymphoid aggregation, which leads to the formation of lingual tonsil, and posterior part of the tongue is connected to laryngeal cartilage, that is epiglottis. Now, please write down. So, what you can write down here? Posterior 1/3 of tongue is containing lingual tonsil. Anterior 2/3 of the tongue on the dorsum part, I mean to tell anterior 2/3 part of the tongue is containing papillae. 4 papillae are there, and the name of these papillae is filiform, fungiform, circumvallate and that of foliate. The foliate is rudimentary, of no use in human beings. Okay, of no use in human beings. The filly is most numerous and it contains no taste bud. The fungi is mushroom shaped and it contains taste bud. The circumvallate is largest one, lying anterior to sulcus terminalis, and it contains largest number of taste buds. So many taste buds are there. If I talk about the lining epithelium of tongue, it is stratified squamous non-keratinized epithelium, but only the filiform papilla is having keratinization. So, only the appearance of the tongue is gritty, hard texture because of the keratinization which is seen in filiform papillae. So, in this diagram also, when you enlarge this, you can clearly see that this larger papillae which you are seeing, which is the largest one, is circumvallate papilla lying anterior to sulcus terminalis. Now, if we will see the inferior part of the tongue, you can see following structures in the inferior part. You can see the deep lingual vein, you can see the opening of submandibular duct, Wharton's duct, and there is ferulinum, which is connecting the inferior aspect of the tongue to the base of the oral cavity. The muscles of the tongue can be categorized into extrinsic and intrinsic muscles. The muscles of the tongue can be categorized into extrinsic and intrinsic. So, we have got 4 important extrinsic muscles: genioglossus muscle, styloglossus, hyoglossus and palatoglossus muscle. The intrinsic muscles are verticalis, longitudinal muscles, and they are exactly required for changing the shape of the tongue. So, we will talk about in brief about the action and attachment of these muscles. So, let us talk about extrinsic muscles. The first muscle is the largest one, that is the fan shaped muscle. This is the genioglossus muscle, which is shown here. So, this muscle which you are seeing is the genioglossus muscle. Genioglossus muscle is arising from superior genial tubercle of the mandible. So, please write down genioglossus muscle. Origin. It originates from superior genial tubercle. Superior genial tubercle inserts on whole of the tongue side process and also to the hyoid bone, inferior fibers of it. It is safety, it is called as the safety muscle of the tongue. And why it is called as the safety muscle of the tongue? Because it is the only muscle which is causing the action of protrusion of the tongue. It causes protrusion of the tongue, and so it is considered as to the safety muscle of the tongue. The next muscle in the quadrilateral shape which you are seeing is the hyoglossus muscle. This is H for hyoglossus muscle. So, please write down the hyoglossus muscle as shown in the diagram. It is attached to the hyoid bone, greater corona and body of hyoid bone. So, write down hyoglossus muscle origin from the greater corona and the part of body of hyoid bone and it inserts into, where does it insert? So, it inserts into the side of tongue. The action is, it is depressure of the tongue, it is the depressure of the tongue, and it makes the dorsum of the tongue, it makes the dorsum of tongue convex. It makes the dorsum of the tongue convex. Now, what about the styloglossus muscle? So, we can see the muscle here. This is the styloglossus muscle arising from the styloid process and merging onto the side of the tongue. Styloglossus muscle. So, styloglossus, let us talk about the styloglossus muscle. The styloglossus muscle originates from tip of the styloid process of the temporal bone and also from the stylohyoid ligament, inserts into the sides of the tongue. So, insertion is inserting into the side of the tongue, and this muscle is causing the action of retraction of the tongue. So, what is the action? It is causing the action of retraction of tongue. Actually, it is moving the tongue sides up and back. The next is the palatoglossus muscle. You can see palatoglossus muscle. Actually, palatoglossus muscle is arising from, if I talk about palatoglossus muscle, this is the muscle arising from palatine aponeurosis of the palate and inserting into the sides of the tongue as shown here, and this is having the action of elevating the posterior part of the tongue and thus approximating the palatoglossal arch. So, write down palatoglossus muscle. The palatoglossus muscle originates from palatine aponeurosis of soft palate, inserts into the side of the tongue, sides of the tongue. Action is elevates the posterior 1/3 of the tongue, elevates the posterior 1/3 of the tongue. That means it approximates the palatoglossal arch. It approximates the palatoglossal arch. Now, that means preventing the food particles to enter into the airway passage. Intrinsic muscle of the tongue is longitudinal, transverse and verticalis, and together their action is to change the shape of the tongue. The arterial supply of the tongue, if I talk about arterial supply, the arterial supply of the tongue is via lingual artery. It is via tonsillar branch of facial artery. Tonsillar branch of facial artery. It is via ascending pharyngeal artery. The venous drainage. The venous drainage is via lingual vein. That is deep lingual vein. And the venae commitans surrounding lingual artery and that of 12th cranial nerve. The lymphatic drainage and the nerve supply. So, in this diagram only I would like to explain the innervations of the tongue. Innervations of the tongue can be clearly understood. Motor supply. All the muscles of the tongue is getting innervation from 12th cranial nerve except palatoglossus, which is innervated from the vagus nerve. This is about motor supply. When I talk about the sensory supply, the anterior 2/3 of tongue is having taste fiber sensation from coda tympanic nerve, that is a branch of facial nerve. General sensation is via lingual nerve, that is the branch of mandibular division of trigeminal nerve. The posterior part of the tongue is getting both general sensation and taste sensation via 9th cranial nerve, and posterior most part of the tongue along with the epiglottis is getting innervation from the vagus nerve. Which branch? Internal laryngeal branch. So, this clear-cut diagram is showing you both the sensory nerve supply and the motor nerve supply of the tongue. In one line, you can say all the muscles getting innervation from 12th cranial nerve except palatoglossus, which is getting innervation from the 10th cranial nerve. Anterior part of the tongue, general sensation, lingual nerve, branch of mandibular division of trigeminal nerve. Special taste sensation is via facial nerve branch, that is coda tympanic nerve. Posterior 1/3 of the tongue along with the circumvallate papilla is getting innervation from 9th cranial nerve, glossopharyngeal nerve, both sensory taste fibers and general sensation. Posterior most part is getting innervation from vagus. Lymphatic drainage, see this, the tip of the tongue is having the lymphatic drainage to submental group of lymph node, the lateral part to submandibular, and the posterior part is going towards the deep cervical lymph node. Now, let's talk about the MCQ related to this. A patient is drinking hot tea. The patient is drinking hot tea at a restaurant, experience a burning sensation at the tip of the tongue. The sensation is transmitted. The sensation is transmitted by which of the following nerve? So, clearly it is asking the tip sensation is by which nerve? My dear, you know that general sensation is by lingual nerve. Taste sensation of anterior part. Taste sensation for anterior part is via coda tympanic nerve. My dear, coda tympanic nerve is a branch of facial nerve and lingual nerve is a branch of 5th cranial nerve. Which branch of 5th cranial nerve? That is mandibular division of the 5th cranial nerve. So, that means trigeminal nerve, that is 5th cranial nerve, is the right answer, because tip of the tongue means the part residing in the anterior part of the tongue, and anterior part general sensation. By sensation, that is burning sensation, that means general sensation, it is carried by the trigeminal nerve, lingual nerve branch. Let's talk about the second MCQ, clinical MCQ. So, let me read it for you. A 35-year-old male comes to your office complaining of a painful tongue sore. He also complains that over last 2 weeks he is suffering from fever and has been experiencing myalgia and arthralgia. He has no other medical problem. The patient works as a driver for local delivery service. He also admits that he is a homosexual, had unprotected sex with a stranger approximately 1 month ago. Physical examination reveals a rash over his trunk and cervical lymphadenopathy. An ulcer was seen on the medial sulcus of the tongue 1 centimeter anterior to foramen cecum. Please note down, it is 1 centimeter anterior to foramen cecum. Okay, you decide to draw the blood test for HIV and want to give analgesic to relieve the pain. So the pain of this ulcer is carried by which of the following nerve? Very easy. Now, my dear Aspen, the key point is here. The key point is the location of the rash or ulcer is 1 centimeter anterior to foramen cecum. And we know that sulcus terminalis posteriorly is meeting at foramen cecum, and this part will be anterior 2/3 part of the tongue, and part posterior to foramen cecum is the posterior 1/3 part of the tongue. That means the question about pain sensation, the next part is pain sensation of this ulcer. That means pain sensation from anterior to sulcus terminalis, that means from the anterior part of the tongue. And anterior part nerve supply is lingual nerve, and we know that lingual nerve is a branch of mandibular division of trigeminal nerve. So the correct answer will be C. Mandibular division of trigeminal nerve is general sensory sensation for this area. So I again want to show you this image where you can see how the sulcus terminalis is dividing, So this is sulcus terminalis, which divides it into anterior 2/3 and posterior 1/3 part, and posteriorly this will meet into foramen cecum. So the ulcer is located anterior to this location, that means here, that means it is in anterior part, and so anterior part of the anterior 2/3 of the tongue, general sensation will be lingual nerve, and lingual nerve is a branch of mandibular division of trigeminal nerve. Now, and another important topic which has MCQ has been come several times is extraocular muscle. So let's discuss this extraocular muscle. So we have got 7 extraocular muscle, 4 recti, 2 oblique, and 1 is levator palpebral superioris. So you can clearly see this all muscles in this image, and what is important for us to know is the action, the nerve supply, and the attachment of this muscle. So firstly, I would like to tell you about the recti muscle, then the oblique muscle, and then the levator palpebral superioris muscle. So let's talk about the recti muscles. So see this diagram: superior rectus, inferior rectus, lateral rectus, medial rectus is not shown here. So all the 4 recti muscle is originating from the annulus of Ginn. Actually, all these recti muscle has got a common origin, and all these recti muscle has got a common origin from the annulus of Ginn, common tendinous ring in the superior orbital fissure. And you can see they are inserting where? They are inserting into the eyeball, and they are inserting anterior to the equator and just posterior to the sclerocorneal junction. Actually, this is sclerocorneal. What is this? Sclerocorneal junction. And they are all inserting posterior to sclerocorneal junction but anterior to the equator. If you will see the oblique muscle, that is superior oblique, inferior oblique, you can see the oblique muscles are inserting on the close to the posterior superior quadrant, and they are inserting posterior to equator and posterior to the sclera of eyeball. So please write down recti muscles. All the 4 recti muscle originates from common tendinous ring, and inserts on sclera little posterior to limbus in front of equator of eyeball, Now, okay. Now, so this is about, so I will discuss about the action of each of the muscle afterwards. Firstly, I want you to complete with the origin and insertion of the muscle. So let's talk about the second muscle, that is superior oblique muscle. The superior oblique muscle originates from body of sphenoid just supromedial to optic canal is the origin, O for origin. If I talk about eye insertion, it inserts into the sclera behind the equator in the posterior superior quadrant of eyeball, quadrant of eyeball. Got it? Now let's talk about inferior oblique muscle. Inferior oblique muscle. Inferior oblique muscle. Inferior oblique muscle is the only muscle which is originating from, it's the only one muscle which originates from the floor of orbit. Okay, from the anteromedial angulation of the floor of the orbit, and it inserts close to superior oblique muscle. That means it will also insert posterior to the equator and close to the posterior superior quadrant of the eyeball. The one more muscle is there, that is called as levator palpebral superioris. So for that, see here, this is levator palpebral superioris muscle, which is inserting into superior tarsal plate and also in the eyelid. And here you can see this levator palpebral superioris muscle. In this diagram you can see it is originating from the sphenoid bone. Actually, levator palpebral superioris is originating from the under surface of the lesser wing of sphenoid bone, inserting in the form of 3 lamina. Superior lamina going into the skin of upper eyelid, which is made of skeleton muscle fibers. Intermediate lamina is made of smooth muscle fibers inserting into superior tarsal plate, and the inferior lamina is going into the fornix of conjunctiva. Levator palpebral superioris is the muscle which is having both skeleton muscle fibers and smooth muscle fibers. The skeleton muscle fibers is innervated by third cranial nerve, that is oculomotor nerve, and the smooth muscle fibers are innervated by the sympathetic nerves. So write down about levator palpebral superioris muscle. Levator palpebral superioris muscle. LPS in short form. Origin. It originates under the surface of lesser wing of sphenoid. Lesser wing of sphenoid. Insertion. I for insertion, it is in the form of 3 lamellae. The upper laminae is made of skeleton muscle fibers, inserting into upper eyelid. The intermediate laminae is made of smooth muscle, and it is inserting into superior tarsal plate. It is inserting into superior tarsal plate, and the lower laminae is inserting into the fornix of conjunctiva. So if I talk about this LPS muscle, this is unique because it is having innervation from both third cranial nerve, the skeleton muscle fibers, and the smooth muscle fibers are getting innervation from, is getting sympathetic innervation, is getting sympathetic nerve supply. So that is the uniqueness of this LPS muscle, which is consist of both motor fiber, skeleton muscle fibers getting innervation from third cranial nerve and sympathetic innervation for the part of the smooth muscle. Now I would like to tell that all the muscles which I have told you, all the extraocular muscles of the orbit is getting innervation from third cranial nerve except LR6 and SO4. What does that mean? That means lateral rectus is supplied by abducens nerve and superior oblique is supplied by the fourth cranial nerve, that is trochlear nerve. Let's talk about the action. So let's talk about the action. So if I talk about the action of extraocular muscles, 7 extraocular muscles are there, and we have to know the individual actions of each of one. Yeah. So actually, if I talk about the action of the muscle is taking place in 3 planes. So there is upward and there will be elevation and depression along transverse axis. There will be adduction, abduction along the vertical axis, and there will be intorsion and extorsion, means rotation of the eyeball inward and rotation of the eyeball outward along AP axis. So let's talk about the action of the muscle, which has been asked so many times in the MCQ. So write down the heading. action of extraocular muscles. The action of extraocular muscles are following. Superior rectus muscle is causing elevation, prime action along with adduction and intorsion movement. Inferior rectus is causing depression, primary action along with adduction and extorsion. Lateral rectus is causing abduction movement of the eyeball. Medial rectus is causing adduction of eyeball. Superior oblique and inferior oblique are very unique muscle because they are causing the action just opposite their name. They are superior oblique will cause depression. Along with it, the other action caused by the superior oblique muscle will be abduction and intorsion. Inferior oblique will cause elevation, abduction and that of extorsion. Now, if I talk about LPS muscle, the LPS muscle is having the action of elevation of eyelid. It causes the action of elevation of eyelid. Elevation of eyelid. Done. Now, let's talk about the clinical anatomy. So, when I am talking about the clinical anatomy, it's important to know when there is an injury of third cranial nerve. So, when there is an injury of third cranial nerve, it means all the muscles of the eyeball, all the extraocular muscles of the eye has been paralyzed except lateral rectus and superior oblique because they are supplied by abduction and fourth cranial nerve. Now, the position of the eye will be, the affected eye will be displaced laterally by lateral rectus and inferiorly by superior oblique. That means the action of superior oblique and lateral rectus will make the eye position looking down and out. If I talk about fourth cranial nerve injury, only one muscle is paralyzed, that is superior oblique. So, patient will have double vision and there is no obvious finding in the resting position and there will be paralysis of superior oblique muscle and the head will tilt away from the site of lesion. If there is a lesion of abduction nerve, that is lateral rectus muscle is paralyzed and the affected eye will be in adducted position. Horner syndrome is seen if LPS muscle is injured and if there is sympathetic innervation of smooth muscle fibers are injured, and in that case there will be Horner syndrome seen. In the case of injury of LPS which is actually injuring the sympathetic nerve supply. Now, let's solve an MCQ here. A 30-year-old male present to the emergency room after being involved in a street fight. There is a significant soft tissue swelling around the eye. The imaging study reveals left orbital floor fracture. So, very nicely it has been seen. We know that when there is an air, it appears to be black in color, and in this case if you will see, there is opacity here and definitely the sinus which is lying close to the floor of the orbit is involved. So, the correct answer will be maxillary sinus. So, definitely in this case the correct answer will be maxillary sinus. In this image, you can see the bones which is forming the boundary for the orbit has been shown and different color has been used. So, very nicely you can appreciate here the maxillary bone has been shown here. The maxillary bone is here and this is shown here in this color. So, this is the maxillary bone. So, definitely the maxillary sinus will be involved in the condition of the inferior aspect of the sinus being involved, maxillary sinus. Now, so in short, we have completed with the head and neck important part, and now I would like everybody to switch into the next topic of the neuroanatomy. Okay, so let's move on to the neuroanatomy. Now, the first thing which I want you to explain in neuroanatomy is, so if I want that a quick revision of important topics of neuroanatomy before your exam, I want you everybody to know about meninges of brain. I want everybody to know about cavernous sinus. I want everybody to know about all cranial nerves. I want everybody to know about all foramina of the skull. So, meninges of the brain. If I talk about the meninges of the brain, there are three meninges from outside to inside. We have got the dura, arachnoid and pia. So, in this diagram, you can see The most outer layer is the dura mater, D for dura. Then we have got the A for arachnoid, and then this is P for pia mater. And these are the layers which is of the layers of the scalp, which is shown here. So we have got three meningeal layers from outside to inside: dura, arachnoid, and pia. The dura mater is mesodermal in origin. The arachnoid and pia is ectodermal in origin, and the arachnoid and pia together is called as leptomeninges. So please write down. This is again showing the layers of the scalp, skull. Then we have got the dura mater of the cranium is having two layers. One is called as endosteal layer, which is on the outer aspect, and on inner side we have got meningeal layer. Then we have got arachnoid mater, and then we have got the pia mater. So firstly, please write down the introduction part. Dura mater is mesodermal in origin. Dura mater is mesodermal in origin. The arachnoid and the pia mater is ectodermal in origin. And the arachnoid and pia together is called as leptomeninges. These all MCQ has been come in previous years, leptomeninges. Now, I would also like everybody to know certain modifications of the meninges. So, we have got certain modifications for the meninges. Actually, meninges, the dura mater is forming folds, that is called as dural fold. Okay, so we have got four important dural folds. We have got four important dural folds which must be known to you, that is flux cerebri, tentorium cerebelli, and that of diaphragma sella. What is important for you to know is that where is this dural fold located and what does it contain. So in this diagram, you can see this diagram is showing flux cerebri, and very nicely you can appreciate this. This sickle-shaped structure which you are seeing is the flux cerebri. This is the flux cerebri, this sickle-shaped structure, and this is sickle shape lying in the medial longitudinal fissure which is located between two side cerebral hemisphere. We can see this is the two side cerebral hemisphere, and this is containing the sinuses, dural venous sinuses, that is superior sagittal sinus, inferior sagittal sinus, and straight sinus. So let's write that about flux cerebri. The flux cerebri is sickle shaped. The flux cerebri is sickle shaped, located in the longitudinal fissure. Where is longitudinal fissure? Between the two cerebral hemisphere. And what does it contain? So it contains superior sagittal sinus. It contains inferior sagittal sinus. It contains straight sinus. Now let's talk about the another fold which you can see in this diagram. This is the cranial cavity which is opened up posteriorly. When the cranial cavity is opened up posteriorly, you can see the tentorium cerebelli. So in this diagram, you can see this is the tentorium cerebelli. So this is exactly the tentorium cerebelli, and what you can appreciate in this diagram, this tentorium cerebelli is a tent-like structure. Actually, this tentorium cerebelli is tent-like structure, and it is forming a suppression. Superiorly, there is an occipital lobe of the cerebellum. So this is O for occipital lobe of cerebellum, and inferiorly there is cerebellum. So it means it is protecting cerebellum from the pressure or the weight of occipital lobe of cerebral hemisphere. So write down that. Tentorium cerebelli is tent-like located in posterior cranial fossa, separating occipital lobe of cerebral hemisphere from cerebellum. Now, contains. Next important thing is what it contains. So it contains superior petrosal sinus and transverse sinus. Now, talking about, so we have done with this. Now, tentorium cerebelli. Next is the, so we have just seen the tentorium. So, this is the enlarged view in which you can just clearly see this is the tentorium cerebelli, the tent-like structure. This whole is tentorium cerebelli. In the posterior cranial fossa, above this like the occipital lobe and below this lies the cerebellum. Two sinuses has been shown as its contents. Two sinuses is the content, and this is the superior petrosal sinus and this is the transverse sinus. So, what is this? This is superior petrosal sinus and this is TS for the transverse sinus as the content of tentorium cerebelli. This is tentorium cerebelli. Now, next comes the flux cerebelli. The flux cerebelli, where it is located, so it is a small sickle shaped fold. So, can you see this is very small sickle shaped fold of the dura mater, and this is located in between the two cerebellar hemisphere and it contains one sinus, that is occipital sinus. So, flux cerebri, the flux cerebri is small sickle shaped dural fold located between cerebellum hemispheres. And what does it contain? It contains occipital sinus. Now, if I talk about diaphragma sella, see this diagram. This is diaphragma sella is present exactly. Diaphragma sella is also called as tentorium it is also called as tentorium hypophysae, and exactly this is located in the sella turcica. What does it contains? It through it passes the stalco-pituitary gland. So, can you see there? This is the stalco-pituitary gland. It is having a gap, and in this gap the stalco-pituitary gland is passing. So, diaphragma sella, the fourth fold. Diaphragma sella is also called as tentorium hypophysae. It contains, through it is having a gap, this means a gap, and through it passes the stalk of pituitary gland. Okay, now we have done with this. Now I would like everybody to know the list of, so we know that other than that I want everybody to know that dural venous sinuses. So we know that there are certain dural venous sinuses which is paired and there are certain dural venous sinuses which is unpaired. Dural venous sinuses images like cavernous sinus has been shown, sigmoid sinus shown, transverse occipital sinus, superior sagittal sinus, inferior sagittal sinus. So what is important for you to know? How it is formed. So, it is formed by the suppression of two layers of the dura mater, that is endosteal and the meningeal layer of dura mater. Other important is that you should know the list of unpaired and paired dural venous sinuses. So, please write down unpaired dural venous sinuses. The list of unpaired dural venous sinuses are superior sagittal sinus, I am writing in short, inferior sagittal sinus, straight sinus, occipital sinus, anterior intercavernous sinus connecting the anterior part of cavernous sinus and posterior intercavernous sinus. These are unpaired. Now talking about the paired dural venous sinuses. So, now write down paired dural venous sinuses. The paired dural venous sinuses are following: sphenoparietal sinus, the cavernous sinuses, the superior petrosal sinus, I am writing in short, inferior petrosal sinus, the transverse sinus right and the left, and the sigmoid sinus. Now, let's talk about the cavernous sinus. Next important thing is the cavernous sinus. So, cavernous sinus is a very important, see here, the cavernous sinus is a very important topic for your FMG exam, and what you can see here in the image, the location of cavernous sinus. The cavernous sinus is located, in this diagram you can appreciate the cavernous sinus is located on either side of the body of sphenoid. It is located in the sella turcica. This is the location. So, you just write down, and what is the reason of formation of cavernous sinus? It is formed due to the splitting of the endosteal and the meningeal layer of the dura mater. So, cavernous sinus is located on either side of sella turcica. After that, I want you to do showing the extent. So, this is the cavernous sinus. It is extending from the close to the apex of superior orbital fissure, and it is extending to the apex of petrous part of the bone, petrous temporal bone. I first want to show you this diagram so that you can appreciate the relations. So, if I talk about cavernous sinus, medially it is related to sphenoidal air sinus, pituitary gland, superiorly by the internal carotid artery, and more laterally is the uncus part of temporal lobe. There are 4 nerves in the lateral wall, 3rd, 4th, 6th. So, actually oculomotor nerve, trochlear nerve, 6th is traversing inside. So, if I talk about 6, it is in the inside, it is not exactly in the lateral wall. Traversing through the cavernous sinus is internal carotid artery and that of abducens. In the lateral wall, we have got ophthalmic and maxillary division of trigeminal nerve. 6th cranial nerve and intercarotid artery is traversing to and through the cavernous sinus. So, please write down these relations. Relations of cavernous sinus. Relations of cavernous sinus. So, medially it is related to pituitary gland, sphenoidal air sinus, sphenoidal air sinus. Laterally it is related to uncus part of temporal lobe. Superiorly it is related to internal carotid artery. Inferiorly it is related to greater wing of sphenoid. Now, the structures residing in the lateral wall. In the lateral wall of the cavernous sinus, following structures are lying: oculomotor nerve, 3rd cranial nerve, trochlear nerve, the ophthalmic division of 5th cranial nerve, and the maxillary division of 5th cranial nerve. If I talk about the structures traversing to and fro, we have got 2 structures. So, 2 structures are traversing to and fro. So, the structures you can write structure passing through cavernous sinus. CS for cavernous sinus, we have got internal carotid artery and we have got 6th cranial nerve. Now, for communications, and I would like to show you this diagram, communications and tributaries. So, by seeing this diagram, you can understand the communication. So, we have got tributaries. Direct tributaries of cavernous sinus is from 3 sources: orbit, meninges, and from brain. When I am talking about orbit, the tributaries are from the source of superior ophthalmic vein, central vein of the retina, and inferior ophthalmic vein. From the meninges, we have got 2 tributaries, sphenoparietal and middle meningeal vein. From the brain, we have got superficial middle cerebral and inferior cerebral vein. I want everybody to please by heart the name of these tributaries from 3 sources. From the orbit, we have got, clearly you can appreciate, from the orbit we have got superior ophthalmic vein, central vein of retina, inferior ophthalmic vein. From the meninges, it is sphenoparietal sinus, middle meningeal vein, and from the brain, it is superficial middle cerebral and inferior cerebral vein. Communication is via superior inferior petrosal sinus, making it a communication with the transverse sinus, inferior petrosal sinus forming a communication with internal jugular vein. Both side cavernous sinus can communicate via intercavernous sinus. Also, the communication is via facial vein, and that is very dangerous. It occurs, actually communication of facial vein occurs via two routes. One route is superior ophthalmic vein, angular vein, and other route is via pterygoid venous plexus and deep facial vein. Now, what happens? The facial vein, which is actually facial vein infection from the danger area of the face, that is below the nose and the area surrounding the upper lip. From there, via facial vein, two routes are there for the communication, and the infection can reach into cavernous sinus. That route is via angular vein, communication of superior ophthalmic vein, pterygoid venous plexus communicating with deep facial vein, and this can lead to a condition called as cavernous sinus thrombosis. Cavernous sinus thrombosis is a very grave condition. You can see the person will have pulsative exophthalmos of the eyeball. The eyeball is protruding outside, breaths and murmurs can be heard because of pulsations. And also there will be internal ophthalmoplegia because all the nerves supplying the orbit, all the nerves supplying extraocular muscle has been paralyzed. Now next topic which I want everybody to note down is cranial nerve. So let's start with the next topic, that is cranial nerve. Okay, now let's starting with the cranial nerve. So I would like to show you this diagram where you can see the 12 cranial nerves has been shown. So where you can see all the 12 pair of cranial nerves has been shown. Olfactory is the first one, optic is the second one, oculomotor is the third one, the trochlear is the fourth cranial nerve, the trigeminal is the fifth, abducent is the sixth cranial nerve, the facial is the seventh cranial nerve, vestibulocochlear is the eighth cranial nerve, glossopharyngeal is the ninth, vagus is the 10th cranial nerve, accessory is the 11th cranial nerve, and 12th is the hypoglossal nerve. So in very brief, I would like everybody to have a brief account of all this cranial nerve. It will be highly beneficial for you. So let's start. So actually, if I talk about first and second, all the cranial nerves emerge out from the brainstem except the first and second. First and second cranial nerve, olfactory nerve is related with the function of olfaction, smell. Optic nerve is related with visual pathway. Now talking about the oculomotor nerve, as I have already given a brief account of oculomotor nerve also. So when I am talking of oculomotor nerve, the major function of oculomotor nerve, it's a third cranial nerve, and the major function of oculomotor nerve is to innervate all the muscles, extraocular muscle, except the two which we have talked. What was that? That was the lateral rectus and superior oblique. So you can clearly see this is showing the oculomotor nerve, and very nicely you can appreciate in this diagram that oculomotor nerve arising from oculomotor nucleus is innervating all the muscle, levator palpebral superior, superior rectus, medial rectus, inferior oblique and inferior rectus, not the lateral rectus and not the superior oblique, So let's now move on. The clinical correlation is also known to you. Oculomotor nerve when is injured, what will it cause? It will cause oculomotor nerve palsy, and in that case the patient condition will be that all extraocular muscle is paralyzed except superior oblique supplied by fourth cranial nerve and lateral rectus supplied by the sixth cranial nerve. So the features will be the eye will have dilated pupil and the eye will be having levator palpebral superior skeleton muscle paralyzed, so it will droop down. So there will be drooping of upper eyelid and the position of eye will be down and out. The eyeball will be in the position of down and out position. Now fourth cranial nerve. So fourth cranial nerve is a very easy nerve because it is the nerve which is giving innervation to just one muscle, and that one muscle is superior oblique. So see here, superior oblique muscle is innervated by the fourth cranial nerve. Abducent nerve is also called as sixth cranial nerve, and it is giving innervation to sixth cranial nerve, and it is giving innervation to just one muscle, lateral rectus. So abducent nerve is giving innervation to one muscle, that is lateral rectus. Coming to trigeminal nerve. If I talk about trigeminal nerve, it is the fifth cranial nerve. It is having three divisions: ophthalmic, maxillary and mandibular. Ophthalmic, maxillary and mandibular. So when I am talking about the ophthalmic division, it is traversing through superior orbital fissure. The maxillary division is passing through foramen rotundum. The mandibular division is passing through foramen ovale. We have to know the branches. So if I talk about ophthalmic, it is the nerve which is giving sensory innervation to the face of one of the three division of trigeminal. It is one of the three division of the trigeminal nerve. It is giving sensory innervation to the whole area of the upper part of the face skin and that of the anterior scalp. So it is having the ophthalmic. If I talk about the ophthalmic division of ophthalmic nerve, that is ophthalmic division of trigeminal nerve, it is having three important divisions and branches: lacrimal, nasociliary and frontal, as you can see in the diagram. Okay, lacrimal, nasociliary and frontal. Now please see the branches. So in this diagram, I want you to show the branches. So in this diagram, you can see the branches of ophthalmic nerve. So you can see the branches of ophthalmic nerve. Lacrimal nerve is giving innervation to lacrimal gland. If you will see the frontal, it is giving two nerves, supraorbital and supratrochlear. If you see the nasociliary, it is giving inferior trochlear, anterior ethmoidal, posterior ethmoidal and ciliary nerves, non-ciliary nerves. So this is the diagram in which all the branches of ophthalmic nerve. So what I want, please don't get frightened by seeing this much branches. Very easy to know. So you just remember the branches, major branches name of the ophthalmic division of trigeminal nerve. Now maxillary. When I talk about the second one, that is the maxillary, the major branches of maxillary is occurring in three areas. It is giving branches in the face area, it is giving branches in the infraorbital canal, and it is giving branches in the pterygopalatine fossa, the maxillary nerve. The maxillary nerve is giving zygomatic nerves, which is again giving zygomatico-temporal and zygomatico-facial nerve. It is also giving nasopalatine, posterior superior alveolar, greater and lesser palatine and the pharyngeal nerve. So branches, what I have shown here is the maxillary nerve branches. So this list is the branches of maxillary nerve. What is maxillary nerve? Maxillary nerve is the second division of trigeminal nerve. Already talked about ophthalmic nerve. When I am talking about maxillary nerve, from the pterygopalatine fossa, it gives following branches: zygomatic nerve, which again divides into zygomatico-temporal and zygomatico-facial; pharyngeal, greater lesser palatine, posterior superior alveolar and nasopalatine. In the infraorbital region, it gives three branches: middle superior alveolar, infraorbital nerve and that of anterior superior alveolar. On the face, it gives inferior palpable nerve, superior labile and lateral nasal nerve. Now the third part of the trigeminal nerve is very important, that is the mandibular nerve, because mandibular nerve branches are more commonly asked. So for that, I will just show you this flow chart where you can appreciate the mandibular nerve branches. So mandibular nerve is the largest component for the trigeminal nerve. It is having both motor and sensory component. Actually, when I am talking about mandibular nerve, from the trunk it gives, so from the trunk it gives one branch. This is called as nerve to medial pterygoid. So this branch, nerve to medial pterygoid, is the branch from the trunk of mandibular nerve. Nerve to medial pterygoid is giving innervation to three muscles. Please note down, trunk of mandibular nerve gives a branch, name is nerve to medial pterygoid. Nerve to medial pterygoid is giving innervation to three muscles. The name of that muscle is tensor tympani, tensor villi palatini and medial pterygoid. Now, the mandibular nerve divides into anterior and posterior division. So, firstly, I would like to talk about anterior divisions. From the anterior division, actually anterior division of mandibular nerve is more of, anterior division of mandibular nerve is mainly motor. Anterior division of mandibular nerve is mainly motor, and the branches it gives are following. So, the branches it gives is deep temporal, branch to the lateral pterygoid, masseteric and the buccal. Actually, only buccal is the sensory. Only buccal is the sensory branch from the anterior division of mandibular nerve. So, if the MCQ comes that which branch of anterior division of mandibular nerve is sensory, the answer is buccal. Deep temporal buccinator, deep temporal masseter and lateral pterygoid branches are all motor branches of anterior division of mandibular nerve. The sensory is just the buccal. Now talking about the posterior division. So when I talk about the posterior division of mandibular nerve, it is mainly sensory, and the three branches are mainly the sensory. It gives three branches. It gives auriculotemporal nerve, it gives lingual and inferior alveolar. See here. So these three branches, auriculotemporal, lingual, inferior alveolar. This is mainly sensory, but the inferior alveolar is giving one branch. The name of that branch is nerve to mylohyoid, which is motor. That means most of the branches of the posterior division of mandibular nerve is sensory except nerve to mylohyoid, which is motor. So got it? Once again if I revise, the mandibular nerve is giving one branch from the trunk. The name is nerve to medial pterygoid, supplying three muscles: tensor tympani, medial pterygoid and tensor villi palatini. Anterior division of mandibular nerve is mainly motor. One sensory branch is gives, that is buccal. The three motor branches of anterior division of mandibular nerve is deep temporal, branch to lateral pterygoid and masseteric. Posterior division of mandibular nerve is mainly sensory. It gives three sensory main branch: inferior alveolar, lingual and auriculotemporal. The inferior alveolar is also giving one motor branch, that is nerve to mylohyoid. So done. Now it's talking about, this is the area of sensory distribution of trigeminal nerve. Only the area you can see around the ear, this area is not getting. On the whole face, the sensory distribution is via the ophthalmic, maxillary and mandibular division of trigeminal nerve, which is shown in this image. Only the area around this ear, that is angle of ear, angle of mandible, this is not getting sensory innervation by trigeminal nerve. This area is getting innervation via great auricular nerve, root value C2 and C3. C2 and C3, great auricular nerve. Now, facial nerve, this is the seventh cranial nerve, nerve of second pharyngeal arch. It's a mixed nerve. Major branches of facial nerve is, it is giving following branches. It is a mixed type of nerve, having both motor and that of sensory component. Major branches are greater petrosal nerve, nerve to stapedius, muscle of the middle ear, posterior auricular nerve, nerve to digastric and stylohyoid, terminal branches, coda tympanic nerve. Actually, 5 terminal branches are emerging out from the anterior border of parotid, and that 5 branches are temporal, zygomatic, buccal, upper lower buccal, masseteric, marginal mandibular and that of cervical. So that means the branches of facial nerve can be greater petrosal nerve, the first branch. Then we have got the branches of nerve to stapedius, coda tympanic, posterior auricular branch, and also the branch to posterior belly of digastric and stylohyoid. The 5 terminal branches are temporal, zygomatic, upper lower buccal and that of marginal mandibular and that of cervical. So in this diagram you can see the terminal branches of facial nerve has been shown. So the terminal branches are temporal, zygomatic, buccal, marginal mandibular and cervical. Temporal branches, as you can see, is supplying the muscles, that is orbicularis. We can see orbicularis oculi corrugator superciliary. Zygomatic branch innervates orbicularis oculi lower part. Buccal branches the other rest area of the buccinator. Zygomaticus, orbicularis oris and marginal mandibular gives innervation to mentalis. Cervical is giving innervation to platysma. So all these information is given here. Now facial nerve when injured, what will happen? The muscles of that means when the facial nerve is injured, that depends on the level of injury. So when it is injuring the terminal branches, just before that all the facial muscle will be paralyzed. If nerve to stapedius is injured, what will happen? The stapedius muscle of middle ear is paralyzed. Greater petrosal nerve, greater petrosal nerve and all is involved, that is the lacrimation will be involved. Then coda tympanic nerve is involved, that means the taste sensation of the tongue will be gone. So that all we have already discussed. Let's talk about the next nerve, that is the let's talk about the cranial nerve. 9th, 10th, 11th and 12th I will talk together. So 9th cranial nerve is glossopharyngeal nerve. So when I am talking about 9th cranial nerve, the important branches I want you to show, the branches of ninth cranial nerve is, it is giving following branches. It is giving branches which is supplying, it is giving a branch which is supplying auriculotemporal nerve, it is supplying the parotid gland, tympanic plexus it forms, stylopharyngeus, it is giving also branch to carotid sinus and carotid body, pharyngeal branch also. Please note down the branches of ninth cranial nerve is, it is giving tympanic branch, carotid nerve, pharyngeal branch. It gives innervation to one muscle of the third pharyngeal arch, that is stylopharyngeus. It gives innervation to tonsillar branch and that of lingual branches. Lingual branch, that means general and sensory taste sensation for posterior 1/3 of the tongue. Glossopharyngeal nerve is also called as the nerve of tonsil. Now, vagus is the vague nerve. Okay, it's the most vague nerve, having a large, huge course along the entire body. And this vagus nerve branches, I want everyone to know. It gives branches to the meninges. It is giving branches to the ear auricular branch, pharyngeal branch. It is giving branches to carotid body, superior laryngeal nerve, superior inferior cardiac branch, and it also gives recurrent laryngeal nerve. It also gives recurrent laryngeal nerve. Okay. Now, accessory nerve is the 11th cranial nerve. Accessory nerve is the 11th cranial nerve. So, accessory nerve is the 11th cranial nerve and it has got two roots. If I talk about the cranial part, it is traversing. So, if I talk about the cranial part, it is traversing towards with the vagus nerve. If I talk about the spinal accessory nerve, it is giving innervation to two muscles, sternocleidomastoid and trapezius muscle. So, see here. The sternocleidomastoid and trapezius muscle is getting innervation from the spinal part of accessory nerve. So, cranial part of the accessory nerve runs along with the vagus, so it is called accessory. Spinal part of accessory nerve is giving innervation to trapezius and sternocleidomastoid part. So, cranial root and spinal root we have talked. Hypoglossal nerve is the 12th nerve and you already know all the tongue muscle is getting innervation from hypoglossal nerve. Now, hypoglossal nerve is giving two branches. One is the hypoglossal nerve proper and one is containing C1 fibers. We know that hypoglossal nerve containing C1 fibers also innervates the thyroid muscle. So, all the tongue muscle is getting innervation from the hypoglossal nerve. We have talked about this in the tongue series, except that of palatoglossus, which is getting innervation from the 10th cranial nerve. Now, the next topic is the cranial foramina. So, we will talk about the cranial foramina. We will talk about all the cranial foraminas located in anterior, middle and that of posterior cranial fossa. So, firstly, I would like to talk about all the, so see here, this area is of anterior cranial fossa. So, this area which you are seeing. So, let me just use this. This is exactly the location of anterior cranial fossa, and in anterior cranial fossa we have got cribriform plate of ethmoid. Here we have got foramen cecum. This is cribriform plate, and anteriorly and posteriorly we have got anterior ethmoidal and posterior ethmoidal openings. We have got the openings there, that is anterior ethmoidal nerves and vessels, anterior ethmoidal foramina is there and posterior ethmoidal foraminas are there. So, please write down the structures passing through the anterior cranial fossa foraminas. So, let us write it. The first foramina is foramen cecum. The structures pass. This is very, very important for your Fmge examination. You should know the name of all the foraminas and you should also know the structures traversing through this foramen. So, foramen cecum, the structures traversing is emissary vein. This emissary vein is connecting nasal mucosal vein with the anterior end of superior sagittal sinus. Now, let us talk about the other foraminas. So, let us talk about the cribriform plate of ethmoid. Through the cribriform plate of ethmoid, The nerves which is passing is olfactory nerve rootlets. Olfactory nerve rootlets. Now, through anterior ethmoidal foramina, the structures traversing is anterior ethmoidal nerves and vessels. Through posterior ethmoidal foramina, the structure traversing is posterior ethmoidal nerves and vessels. Now talking about middle cranial fossa. So let's talk about middle cranial fossa. So now I am concentrating, this is exactly the area of middle cranial fossa. So this is exactly the area of middle cranial fossa. The foramina which is seen here in this location is optic canal, superior orbital fissure, foramen rotundum ovale, foramen rotundum, FR is this is FR, this is ovale, this is the ovale one. Then we have got small one, foramen spinosum is this, and this irregular foramen is lacerum. So we have got foramen spinosum and lacerum. All these foramina, so it's very important that we should know the structures passing through all these foramina. So let's write it. So let's write the middle cranial fossa foraminas. Through optic canal. So through optic canal, the structure traversing is optic nerve and ophthalmic artery. Through foramen rotundum, maxillary nerve traverses. Through foramen ovale, what passes? Male passes, M-A-L-E. Here M stands for mandibular nerve, A stands for accessory middle meningeal artery, L stands for lesser petrosal nerve, and E stands for emissary vein. Now, let's talk about foramen spinosum. What passes through foramen spinosum? The structures passing through foramen spinosum is middle meningeal artery and nervus spinosum. Now, the structures traversing through foramen lacerum. So, the structures traversing through foramen lacerum is following. Meningeal branch of ascending pharyngeal artery, meningeal branch of ascending pharyngeal artery, emissary vein, which is connecting the cavernous sinus to pterygoid venous plexus, which is connecting the cavernous sinus to pterygoid venous plexus. Also, internal carotid artery traverses along with the sympathetic plexus. And greater petrosal nerve, actually greater petrosal nerve enters the posterolateral aspect and leaves the anterior part of foramen lacerum, joins with the deep petrosal nerve and forms nerve of pterygoid canal. Now, so in short, but we have not talked about superior orbital fissure. I think we have not talked about the superior orbital fissure. For that, I would like to show you a diagram. So superior orbital fissure, you can see in the orbit, this retort tape, this is superior orbital fissure, which is a retort shaped, and actually this superior orbital fissure which you are seeing is divided by a common tendinous ring into 3 parts. So we have to know the contents of these 3 parts. So it is important that we should know the content of all these 3 parts: lateral, middle, and that of the medial most part. That is lateral, middle, and the lateral, intermediate, or you can say middle part, and the medial most part, and we should know all the structures traversing through it. So see here, through the lateral part, if I talk about the structures passing through the lateral part of superior orbital fissure, following structures are passed. LFT is the mnemonic. LFT means lacrimal nerve, F for frontal nerve, T for trochlear nerve. So this is LFT is the most important content. Other than that, superior ophthalmic vein and recurrent branch of lacrimal artery. So this structure is passing through which part of superior orbital fissure? The lateral part of superior orbital fissure. That is this part. Now talking about the superior orbital fissure middle part. When I am talking about the structures traversing from middle part, the structures traversing through the middle part of superior orbital fissure are superior and inferior division of third cranial nerve, oculomotor nerve, along with the nasociliary nerve and along with the sixth cranial nerve, abducens nerve. Now, structures passing through the medial most part transmit through structures of superior orbital fissure, inferior ophthalmic vein and sympathetic plexus, from the which sympathetic nerve arises from the plexus which is accompanying the internal carotid artery. Okay, now I would also like to talk about the structures traversing through posterior cranial fossa. So in the posterior cranial fossa, we have got internal acoustic meatus. Internal acoustic meatus, and the structures traversing through internal acoustic meatus is 7th cranial nerve, 8th cranial nerve, nervus intermedius, that is the sensory component of the 7th cranial nerve, and that of labyrinthine vessel. Now structures passing through hypoglossal canal or anterior condylar canal of foramen. The 12th cranial nerve passes through this. 12th cranial nerve passes also 12th cranial nerve also meningeal branch of ascending pharyngeal artery traverses. Meningeal branch of ascending pharyngeal artery traverses through it. Sometimes there is a presence of posterior condylar canal also, and the structures traversing from the posterior condylar canal is the emissary vein. To be more particular, which emissary vein? The answer is this emissary vein is connecting suboccipital venous plexus with that of sigmoid sinus. So this emissary vein, which is passing through posterior condylar canal in the posterior cranial fossa, is forming a communication with suboccipital venous plexus and that of sigmoid sinus. Other than that, we have got jugular foramen and foramen magnum. So this is the outline of the jugular foramen. Why I have used this? Actually, jugular foramen has got many structures traversing through it. It can again divide in 3 parts. So you can see from the anterior part, inferior petrosal sinus, middle part, 9th, 10th and 11th cranial nerve, and through the most posterior part, we have got the emissary vein along with the meningeal branch of occipital artery and the sigmoid sinus forming junction with the internal jugular vein. So see here, the jugular foramen is divided into 3 compartments. As I told you, from the anterior part of jugular foramen, only one structure traverses, that is, only one structure traverses through the anterior part, and through the anterior part, the structures traversing is inferior petrosal sinus. Through the middle part, 9th, 10th and 11th cranial nerve are traversing. 9th, 10th and 11th cranial nerve is traversing. And through the posterior part, following structures traverses sigmoid sinus, meningeal branch of occipital and that of ascending pharyngeal artery. Now let's talk about the compartments or the foramen magnum. See this foramen magnum. So actually foramen magnum is present in the posterior cranial fossa. So this is an enlarged view. So we can divide it into two compartments, A and P, by the alar ligaments, and we have to know the structures traversing through the anterior part of foramen magnum and the structure traversing through the posterior part of foramen magnum. FM for the foramen magnum. So very nicely I told you the whole of the foramen magnum can be divided into two compartments. The alar ligament divides foramen magnum into two compartments, anterior and the posterior. Now structures traversing through anterior compartment is just the ligament. So the structures traversing through anterior is just the ligament. So it is called as osteoligamentous compartment. And the structure are apical ligament, upper band of cruciate ligament and membrana tectora. No nerves and vessel traverse. From the anterior part, only ligaments, mainly membrana tectora, apical ligament of the dens and upper band of cruciate ligament. Major neurovascular structures are transmitting from the posterior part of foramen magnum, and these structures are lower part of medulla oblongata, fourth part of vertebral artery, surrounded by sympathetic plexus of nerve, accessory nerve, anterior posterior spinal nerves and tonsil of cerebellum. So I want my dear aspirants to by heart all these important things, all these structures and foraminas which I have told you and the structures traversing through it. It is highly, highly important for you. So these are the structures which is passing through the posterior or neurovascular compartment of foramen magnum. Now let's solve the MCQs related to this. So let me read it for you. A 67-year-old woman with metastatic lung cancer complains of recent hoarseness and difficulty in swallowing. On examination, there is loss of gag reflex on left side and uvula deviates to the right side when the patient is telling ah. There is also weakness of sternocleidomastoid and trapezius muscle. Which of the following structure is involved? So the key feature is sternocleidomastoid and trapezius is injured. That means which nerve is injured? 11th accessory nerve is injured. Now, patient is not able to speak the word and uvula is deviated and ah word is not, means pharynx, soft palate, all is involved, and we know that is supplied by vagus nerve. Okay, so 10th, 11th, and we also know that in case of gag reflex, the 9th cranial nerve is involved. So my dear, 9th, 10th and 11th cranial nerve is involved. So which is the foramina involved? The answer is jugular foramen. So the correct answer is jugular foramen. The correct answer will be jugular foramen. Got it? Now let's talk about the second other MCQs. Which foramen transmit nerve branch to meninges? Among this, which is a foramen which is giving nerve branch to meninges? So if you remember, I told you that there is a foramen named foramen spinosum, and this foramen spinosum, which nerve passes? Nervus spinosum. Nervus spinosum is a branch also from the mandibular trunk, and so A is the right answer. Foramen spinosum is the foramen through which branches to meninges traverses. The right answer, nervus spinosum passing through foramen spinosum. Foramen spinosum transmit meningeal branch of mandibular division of 5th cranial nerve. Foramen magnum, the big foramen in the posterior transmit all except the options is medulla, covered with the meninges, vertebral arteries, spinal root of accessory nerve, dural veins and internal carotid artery. My dear, the internal carotid artery never traverses through the foramen magnum. It traverses through the carotid canal, which is seen more clearly in the base of the skull. So actually internal carotid artery is not traversing the foramen magnum. Rest all structure, yes, medulla traverses, vertebral artery traverses, spinal accessory nerve traverses. Also dural veins traverses through it. So if I have to choose the odd man out, the internal carotid artery is not passing through foramen magnum, which is situated in the posterior cranial fossa. Structure passing through foramen magnum is medulla, meninges, vertebral arteries, spinal accessory nerves, anterior and posterior spinal arteries. Jugular foramen, which is also located in the posterior cranial fossa, transmit all of the following except options are glossopharyngeal nerve, vagus nerve, accessory nerve, inferior petrosal sinus, sigmoid sinus, and sympathetic plexus. Jugular foramen transmit all except, question number 3, jugular foramen transmit all except. So, jugular foramen is not transmitting any kind of sympathetic plexus. So, please note down, it is not transmitting any kind of sympathetic plexus. Rest all 9th, 10th and 11th cranial nerve always traverses through jugular foramen middle part. Inferior petrosal sigmoid sinus also traverses. So, the correct answer will be E. Jugular foramen transmits 9th, 10th, 11th cranial nerve along with inferior petrosal sinus, sigmoid sinus, along with the meningeal branch of occipital and ascending pharyngeal artery. Foramen of cribriform plate, which is located in the anterior cranial fossa, transmit which of the following structure mentioned? Axon of olfactory cells, posterior ethmoidal arteries, ophthalmic arteries, sympathetic plexus or dural veins. Which is the correct answer, my dear aspirants? We know that from the cribriform plate of anterior cranial fossa, the structure traversing is olfactory nerve rootlet. What does that mean? Olfactory nerve rootlet means axons of olfactory cells. So, the correct answer will be A. Same thing it is written. Foramina in cribriform plate transmit axons of olfactory cells. In addition to optic nerve, optic canal transmit which other structure? We know that optic nerve through which optic canal, if I talk, two structures is passing. Two structure. One is the optic nerve, another is, just now I told you, whether it is third cranial nerve, oculomotor, internal carotid, nerve branches to meninges or ophthalmic artery. My dear, the correct answer is ophthalmic artery. We know that optic canal, say those structures traverse hote, two structures traverses, one is the ophthalmic artery and the other is optic nerve. So, optic canal transmits two structures, optic nerve and ophthalmic artery. Maxillary division of trigeminal nerve is transmitted through which of the following cranial foramina? Maxillary division of trigeminal nerve is transmitted through which of the following cranial foramina? The options are foramen rotundum, foramen ovale, superioorbital fissure, foramen spinosum, foramen lacerum. What is the correct answer, my dear aspirants? Please mark it. The correct answer is foramen rotundum. Through foramen rotundum, maxillary division of trigeminal nerve traverses. Which foramina is located in anterior cranial fossa? So, the location of foramina in the anterior cranial fossa. The options are foramen cecum, optic canal, superioorbital fissure, foramen ovale and condylar canal. My dear aspirants, we know that foramen cecum is the foramen through which emissary vein connecting nasal mucosal vein and the straight sinus, superior sagittal sinus. So, emissary vein is passing through the foramen cecum, forming a communication. So, this emissary vein which is passing through foramen cecum is forming a communication between the nasal mucosal vein and superior sagittal sinus. So, the correct answer is foramen cecum in anterior cranial fossa. Which foramen is not transmitting any kind of emissary vein? It is not transmitting any kind of emissary vein. Foramen cecum, condylar canal, mastoid foramen, parietal foramen, anterior ethmoidal foramen. My dear aspirants, foramen cecum, yes, it transmits emissary vein. Just now I told you. Condylar canal से भी emissary vein pass करता है, mastoid और parietal foramen से, so definitely emissary vein pass करता है. It is shown on the skull superior aspect. Anterior ethmoidal foramen is the right answer because through anterior ethmoidal foramen only anterior ethmoidal nerves and vessel passes. No emissary vein passes through it. Not a single emissary vein passes through it. See the explanation. Anterior and posterior ethmoidal nerves and vessel passes through anterior and posterior ethmoidal foramina. No emissary vein passes through this. So, definitely E is the right answer. Superioorbital fissure transmit all of the following except ophthalmic division of fifth cranial nerve, maxillary division of fifth cranial nerve, third cranial nerve, fourth cranial nerve, or the sixth cranial nerve? My dear aspirant, we know that maxillary division of trigeminal nerve is passing through foramen rotundum and it is not passing through the superior orbital fissure. So, the odd man out is maxillary division of trigeminal nerve. Other structures, ophthalmic, third, sixth and fourth is passing through, fourth cranial nerve is passing through superior orbital fissure. Same thing. Now, all transmit arterial branches to meninges except foramen ovale, foramen rotundum, groove of greater petrosal nerve, jugular foramen and mastoid foramen. So, all of this transmit arterial branches, means arteries are given to the meninges except which is the foramen which is not giving any, So, yes, we were in which question? So, which is the foramen which is not transmitting any meningeus branch, means arterial branch to meninges is not given. The correct answer is foramen rotundum, because through foramen rotundum, the nerve passing is maxillary nerve and not an arterial supply is passing. Foramen ovale se pass karta hai, definitely pass karta hai accessory middle meningeal artery, and also meningeal branches are passing through mastoid, jugular and the greater petrosal nerve groove. So, see here I have written the details. Through foramen ovale, the meningeal branch is passing accessory meningeal artery. Through foramen spinosum, middle meningeal artery itself passes. The groove of greater petrosal nerve transmitted petrosal branches of middle meningeal artery. The jugular foramen also has got meningeal branches of occipital and that of ascending pharyngeal artery. Mastoid foramen also through it passes meningeal branch of occipital artery. So, we can see that all these foramina which was mentioned except foramen rotundum, through which only maxillary nerve passes, foramen ovale, foramen spinosum, greater petrosal nerve groove, jugular foramen and mastoid foramen, all is giving any arterial supply to the meninges. So, the odd man out here is the foramen rotundum. So, my dear aspirants, so we can end the session and hope a quick revision of many important topics which will be highly beneficial for your FMGE examination, and I wish you all the best. So, just crack the examination, give your 100%, go through all the things which I have tried my level best to complete all the important aspects which is possible in this less span of time, and I hope the session is useful for you. My all blessings are with you. All the best, my dear, and just crack the examination, give your full 100%, don't take tension. The less time is there, so that is to concentrate and revise. Not a new topic has to be done in this time. If you have not completed any segment, it is not a time that you will start on a new. So, just revise what you have done. And what I will tell you, last 5-year MCQs, go and solve all last 5-year MCQs of FMG papers, and you can also solve last 5 years question of NEETPG examination, because there is nowadays overlap of questions being seen. So, that would be highly beneficial for you. All the best, my dear aspirants. Crack the examination. Thank you so much. So, keep your fingers crossed and just hope for the best and be optimistic. Please don't let any negative thoughts come in your mind. Just be positive that you are going to crack it definitely. Thank you so much. Thank you, dear. So, I will meet you in the next session soon. Thank you. All the best. Good luck.